Everybody please take your seats. Our guests have arrived. We'll start in another minute. To my NHA colleagues, can we ensure everybody seated in? Request everybody to please move into the room. Request everyone to please be seated. If you're standing, grab a chair that's closest. Please sit down. Folks standing near the door, will request you to please take a seat. Thank you everyone who's back in the room. Hope the tea, coffee was re-energizing. We have an exciting conversation lined up. Thank you so much for joining in. We welcome you to the first plenary session of Arogya Manthan 2023 on universal health coverage through convergence and digitization. In the next 90 minutes, the session will aim to bring forth conversation on the attainment of universal health coverage with the invention of technology, integrated IT platforms, and standardized processes, and showcase the progress of UHC through PMJ, ABDM, and convergence. To kick off this session, we have a distinguished panel today of policymakers, researchers, practitioners who've been leading the efforts of UHC from the forefront. First, I would like to invite the chairperson of the panel, Dr. V.K. Paul, a globally recognized medical scientist and public health expert. He currently serves as member health, where he leads the Niti Aayog, where he leads the health, nutrition, and HRD vertical. He has shaped major healthcare initiatives, which includes ABPMJ and Poshan Abhiyan. Next, I welcome Dr. Indu Bhushan, a former Indian bureaucrat and economist. Dr. Bhushan has a career spanning 4 decades across a multitude of sectors, working with institutions such as the World Bank and ADB. Formerly, he has served as the first CEO of the National Health Authority, leading the design and rollout of both the schemes. Welcome, sir. Next, I'd like to invite Dr. Atul Goyal, a distinguished medical professional and who currently serves as the Director General Health Services in the Government of India. He has also served as the Head of Department of Medicine and Vice Principal at Lady Hardinge Medical College and has a career spanning decades across teaching and practicing internal medicine at leading institutions. Welcome, sir. Next, I invite Shri Amit Agarwal, CEO of UIDAI, an accomplished IAS officer with the pivotal roles in central and state governments, including Additional Secretary in Electronics and IT and Joint Secretary in Finance. He's contributed significantly to corporate boards in technology, banking, insurance, and public sectors. Lastly on the panel, I also invite Shri Gagandi Bedi, a senior IAS officer currently serving as Principal Secretary Health, Government of Tamil Nadu. In his 30 years of service, he has served across a wide portfolio, particularly recognized for his efforts during COVID in Greater Chennai Corporation and his contributions to the ecology and environment. And lastly, I welcome Dr. Basant Garg to the stage to moderate the session. Dr. Garg, an IAS officer currently serving as the Mission Director ABDM and Additional CEO National Health Authority. He's overseeing the implementation of both the schemes PMJ and ABDM. So handing over the stage to you to kick us off with the presentation. Thank you.
I once again welcome all the participants who have joined us today. I extend my warm welcome to our esteemed chairperson and panelists as we commence the Manthan. Let me at the very outset outline the objectives of our plenary session. We need to understand major requirements to achieve universal health coverage and showcase the progress that has been achieved by Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana and Ayushman Bharat Digital Mission, and also discuss the impact of these initiatives and maybe have some sense of a future roadmap to achieve universal health coverage. At the very beginning, I would, in order to set the context, I would seek permission from the chair. I would like to present make a presentation so as to inform our audience about the recent developments in universal health coverage. Thank you, sir. So Ayushman Bharat PMJ, how does this scheme help us move towards universal health coverage? The scheme addresses three important factors which aid or the lack of which hinder achieving universal health coverage. The most important being accessibility. As we all know, PMJ at present caters to bottom 40% of India's population who otherwise would not have access to many of the private health facilities, who would not have access to some of the public health facilities as well. It also addresses the problem of affordability. The government, being the largest procurer of services, steps in and assumes the role of price setting, thereby altering the market in favor of poor patients. And third important part is quality. Ensuring quality in healthcare, decongesting public hospitals, and allowing private hospitals, private facilities to come up in tier 2, tier 3 cities. Where are we now? As you can see, PMJ with the bottom 40% of population caters to close to 12 crore households, 12 crore families. 26 states have already expanded beneficiary base beyond 12 crore by another 5 crore, thus taking the total coverage to about 17 crore families. Add to this a large number of government employees and pensioners, people covered under the ESIC scheme. Then there are people who avail private insurance. We do have a large set of our population who are assured healthcare by one or the other means. Of course, we would request the three non-implementing states to quickly join Ayushman Bharat PMJ so as to enjoy the benefits of single, large procurer. I know the states are implementing their own schemes and they are doing it very well, but we would really like to have them under the PMJ banner. How does PMJ help in efficiency? So as you can see, with the number of treatments, hospitalizations that have taken place, had those hospitalizations been taken at the prevalent prices per episode cost in public or private hospitals, the expenditure would have been close to 1,08,000 crore. Whereas the expenditure under the scheme till now is close to 69,000 crore rupees, thereby the notional saving of close to 40 crores, 40,000 crores. That is the saving to the overall healthcare system. That is the efficiency which PMJ brings in, and that is the factor which price setting brings in to the system. So consolidation of demand, there is standardization of packages. All these measures are leading to a lot of savings. We are just talking about savings from the system. So had the citizens availed these services from their own pocket, individually, they would have spent much, much larger amount for the same set of services. Where are we now? I think I will not dwell more on this slide. My CEO in his inaugural presentation has already given us these statistics, so I'll skip this. So there are ways to achieve universal health coverage as we understand it. One is across the board expansion, wherein more and more people, more and more poor people are covered under the scheme. And another way is that we pick up specific population groups, vulnerable groups, and then we converge those schemes in order to include them. So these are the two ways. One is the expansion as a across the board population subset, and one is convergence, wherein we pick up specific already existing schemes, already existing population groups which can be added. This matrix gives us the considerations for USC. Of course, population is one part, wherein the beneficiary base expansion is an important part of ensuring universal health coverage. A very important part is services. What kind of services are included in the universal health coverage? These include preventive services, primary, and then of course secondary and tertiary care. As of now, PMJ only caters to secondary and tertiary care and palliative care at best. Preventive and primary care, even today, is out of ambit of PMJ, but they are covered by another pillar of the Ayushman Bharat, that is the Ayushman Bharat Health and Wellness Center and other government programs. And of course, the most important part is the money. Where does the money come from? How do we converge various government schemes so as to ensure there is no wasteful expenditure, no duplicate expenditure, and there is convergence to obtain the best results. And how do we ensure this convergence? One of the very basics of convergence is a database, Aadhaar seeded database, which can be used to deduplicate, to prevent citizens from availing services from different schemes, different sources. So that is the very, very basic. We do need an IT platform to deliver these services, and that NHA has already developed and is being used, as I will show in my further slides, by various schemes. We need to develop standardized claim processing mechanisms. And then, of course, at a further later stage, a standard providers network, maybe hospitals, a similar package, a uniform health benefit package, and at a very later stage, maybe a common budget and administration for funding these services. What is the status of convergence today? 26 states, as highlighted earlier, have already converged their state-specific schemes with Ayushman Bharat PMJ. Then there is Pandit Deen Dayal Rajya Karamchari Cashless Yojana of UP. There is schemes from Uttarakhand and Nagaland which are already converged. These are employee schemes. And at the central level, we already have ESIC in 157 districts. We have BOCW in 7 states. We have PM Cares for Children. There are many more schemes to follow which are under consideration. There is a CGHS pensioner scheme which is already converged on the NHA IT platform. All of CAPF, that is converged. And then, of course, ministries, Rashtriya Arogya Nidhi and HMDG, Health Minister's discretionary grant. So these are some of the schemes which are already converged on the NHA IT platform and are being they are being delivered, services are being delivered using this platform. And this brings us to one more important component of universal health coverage, the digital health ecosystem. We need to have trusted players in the digital health ecosystem, trusted patients, unique IDs issued to all patients, trusted healthcare professionals, and trusted healthcare facilities. And of course, then there are other registries which we need to make to enable all this. A very important component is digitization of health records, availability of electronic medical records. And then we have to ensure seamless exchange of information and putting the patient in the center of it so that the patient is in control of his or her health record. And a very important part is the continuum of care, wherein a patient treated in one kind of a program or a facility, it's not that he's treated and then he's forgotten, he's let go. It's that he's taken care of, his follow-up is there, it leads to largely a health change in the health-seeking behavior as well. So that is the extent to which this continuum of care would extend. It will also include components of quality of care given and the quality of follow-up. Where do we stand? We are developing these registries, the unique identifiers for all stakeholders, ABHA for all citizens, the healthcare professional registry for healthcare professionals, the healthcare facility registry, the HFR for health facilities. And these, we feel, will enable us to uniquely identify people and develop a digital health ecosystem. Where are we? I think again in the inaugural session, my CEO has already given you all this information. What percentage of population already has ABHA? Quite a lot of number of doctors, professionals, and facilities are already registered with us. So we'll not delve into this. Based on these registries, we are developing the digital public infrastructure. We will talk about this during whole of remaining part of the day today and whole of tomorrow. We are developing the health claims exchange for interoperability between health claims, leading to more efficient claims processing. A health information exchange and consent manager for interoperability of health information. And then, of course, the unified health interface for interoperability of health services, leading to more discoverable services for the citizen. And then this, why are we doing all this? How does it contribute to universal health coverage? These are the benefits to the government, to the citizens, and to the healthcare providers. As you can see, overall, the digital mission aims to bring efficiency, cost effectiveness into the system, and to change the way health services are being availed of and being delivered today. So we have to move to the new system. So that is how digital mission tries to address the issue of universal health coverage. And of course, the synthesis of all three, Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, Ayushman Bharat Digital Mission, and various convergence of various government programs under the same umbrella of Ayushman Bharat, how that leads to universal health coverage. I thank you all for allowing me to make this presentation. I'll quickly again seek permission from the chair to I'll start with the questions, sir, with your permission, and then we'll come to you, sir, for summing up the discussion. My first question is to our first CEO, Indu Bhushan, sir. Sir, how do you feel NHA can support UHC, universal health coverage? What role NHA has for this, sir?
Thank you, Basant. Thank you, first of all, for inviting me. And of course, NHA and both these schemes are very close to my heart. And the first CEO, I can say, in the best or most prominent well-wisher of these schemes. So, of course, Ayushman Bharat PMJ was launched by the Honorable Prime Minister with the aim of doing universal health coverage, because we know that there are a large number of people who don't have affordable access to health schemes and to health and medical care, quality medical care. And your question that how does NHA support or these schemes support universal health coverage is, I think, quite obvious, because when we talk about or think about PMJ, the first thing that comes to our mind is affordability, that it makes health care, medical care affordable to those who don't have access or effective access so far. As we know that 70% of the services in the country are provided by the private sector, and which is largely accessed by non-poor, and poor for the first time has that capacity to access quality services both in public sector and private sector, and that too in large numbers, that more than 500 million, and if we add all the schemes that we have added from states, more than 65 crores or 650 million, which is the access or the reach of the scheme. But if we just look at the affordability, I think we are undermining the impact or the potential impact of the scheme, because the scheme PMJ does much more than making them affordable. It, as you spoke, Vasant, that it actually helps in terms of improving the efficiency. And if you look at the theory behind it, that if you have risk pooling and strategic purchasing like you've done through NHA, then you can reduce prices, you can set benchmarks for pricing, and that helps in terms of reducing cost and improves efficiency. So of course you need efficiency, because if you want to reach everyone, you need to have efficient delivery of services, and this scheme helps in terms of improving efficiency. Third thing is that it also improves in terms of improves quality of services. And NHA and schemes, once you are dealing with large number of providers, you can set benchmarks, you can set what you call as standard treatment guidelines, and insist that those standard treatment guidelines should be followed, and ensure that quality services should be provided, not only any services, but quality services, and that this scheme is going to be helping in terms of improving the quality of services if we do it well. Fourth thing is that it will also expand the access to services. And since now I am out of the government and I can see what's happening in the sector, I can already see that there is that willingness to invest more in tier 2, tier 3 cities, and there are PE funds and others who are willing to take up a call for investments and expanding private sector health networks in those areas where so far there was the areas were underserved. And the reason is that earlier there was no demand, and the demand was not enough for private sector to be justified, private investment to be feasible. Now, since Ayushman Bharat has created that demand, and the government is providing those resources for people to access services, there is a supply response also. And if it was not for the 2 years that we lost because of COVID, we would have seen much more of that. But in coming years, we'll see a lot of other services, private sector investments going into underserved areas. So that once, for universal health coverage, you just don't need demand side, but also supply side. You need to have supply of good quality hospitals. So what I'm saying is that while we are dealing with affordability, PMJ is also dealing with efficiency, it's also dealing with quality of services, and it is also dealing with the supply of services through expansion and providing incentive for private sector to support. So in that sense, it has been a transformative scheme which is helping the sector in a big way. But it doesn't stop at those. It is also providing impetus for digital health. Even before NDHM came up, this scheme had created a unique ID for large number of people, because every Ayushman Bharat beneficiary has a unique ID. Every hospital which has been impaneled has an ID, and all the treatment which are being provided are digital, and we are linking that with those IDs. So whatever now NDHM is doing, our Ayushman Bharat PMJ was doing even before that, right? And that was the reason that NHA was given the responsibility of implementing and starting NDHM now, which is the ABDM. Therefore, this scheme provided the impetus for deepening digital health in the country. And what you mentioned here, again, Basant, that also provided the fulcrum on which now we can do the continuum of care, because we are dealing with the tertiary care and upper secondary care. But like this morning or this early afternoon, Dr. Paul was mentioning that if we work well with now health and wellness centers, both in terms of backward and forward linkages, we can strengthen continuum of care through this scheme in the country.
Thank you, sir. I think you've set the agenda right, sir. NHA is working to improve efficiency, quality, and access. One of the questions which keep repeatedly coming up, is the work done for trust. We talk about trusted actors, but whether the private sector trusts the government, whether the citizen trusts the government, and we have amidst us Amit Agarwal, sir, CEO of UIDAI. So I would quickly like to ask, sir, how do we address these concerns around, privacy of data, concerns around, the attitude of the fear that the big brother is watching you when citizens are concerned about their health records? So how do we address that, and what measures government is taking in that field, sir?
This is, of course, an idea which has been uppermost in the minds of all the digital citizens of this country for many years. And I'll respond at two levels. One is Aadhaar, which is about the digital identity, and the second is about digital data in general, which is data linked to Aadhaar or otherwise in general. So we had this long debate. The Supreme Court evaluated issues, Parliament enacted a law, and if you recall the history, 2016, the Act came and Supreme Court decided the matter. And those people who are conversant with the law or otherwise, I don't think there has been anything which has, which is not privacy preserving. The Act says that the authority, UIDAI, is purpose blind. It does not know, even let alone reveal to somebody else. It is prohibited by law from knowing what citizens are using their identities for the purpose for which it is applied. It confirms the identity. It is essentially a pinging machine where an identity is submitted voluntarily, and once it is submitted, it merely confirms whether that identity biometrically or in respect of personal details, which we call demographic information, is the same. It matches or it doesn't match, and it simply responds with an eKYC packet or a yes/no. So it is what we call privacy by design, privacy by policy, and security. Those were the three cornerstones, and this is how it's been constructed. And this is how it has worked across the years. And data has been secured, privacy has been preserved, and it is all there by law and by technology and by policy, all three. So that is as far as the identity goes. And like Basant said at the outset, that Aadhaar is like it's a bit like the common KYC system for the financial sector, CKYC number, where there can be a number of officially valid documents like driving license, passport, etc. But since this is a digital means of submission, is always the easiest for people to work with. People of this country, by and large, even though Aadhaar has been voluntarily, has chosen by and large they have actually voted by choice for Aadhaar, and that is understandable. And the mainstay for identity in any sectoral identity system continues to be Aadhaar. The second part of trust is personal data in general. The health data of individuals is something very valuable to everybody, and understandably everybody should be concerned about that data. And the absence of a data protection law for long was a source of concern. So while there was a special act to deal with digital ID, namely Aadhaar in particular, it was a specific legislation for a specific piece of digital personal data. There was no general law in place which was effective. Now that Parliament has enacted and the law is out there in the public domain, and as a member of the Ministry of Electronics and Information Technology, I can just apprise you that the rule-making process is on, and rules will also similarly be transparently out there for people to go by. But the Indian data protection law has all the general cornerstones of proportionality, data minimization, all of those general principles which are common to data protection laws across the world. But beyond that, it has several unique features which are not there in several other laws and which are extremely useful. We are all aware that when you go online, you are asked to submit some consent form, and the truth of the matter is most of us, myself included, half the time don't really read that consent form. And in order to access a service, you sign that. A unique thing in the Indian law is that consent is defined, the consent provision itself says that if you have taken consent for beyond what was necessary to provide the stated service, the stated purpose, then that is by law no consent. Having taken such a consent and and then just use the data, the law itself de-recognizes it. That consent, that contract, that agreement is of no value. It will not protect the person taking the data. So this is unique. No country has done that. Similarly, when the consent is given, the consent has to be accompanied or preceded by a notice. And just like to ensure on the same principle that consent must be informed, the law says that the person must have an option to view the consent in English or any of the 8 scheduled languages, which is 22 languages. This is basically to ensure that at the stage of taking consent, you may not offer services in every language, but when data is being taken, the person has a right to know in their own language, a language that they understand, what exactly is being done. So it is multilingual by law. As and when the law comes into place, every entity, NHA included, will have to give a notice for consent in every language and give people a choice to view it. The third thing is when consent is given, while taking in the consent notice itself, every data fiduciary is to inform the data principal that this consent is withdrawable and the manner in which it is withdrawable, that they have a right to grievance redressal and a manner in which the grievance redressal may be sought, and that if they are not satisfied with the grievance redressal, the right to make a complaint to the Data Protection Board of India and the manner in which that may be done. So at the outset, the initial consent must tell them how to withdraw, how to seek directly relief from the data principal, and if not, how to approach the Data Protection Board. On the manner of, again, the ease of doing things, it is a modern law, it is a digital law. So like for withdrawability, it says the withdrawability must be similar in ease as the ease of giving consent. So you can't make easy consent at a click, but withdrawal you are made to run around the hoops, you produce this, that, or the other. It has to be, if you're doing it on the home page or a home screen of an app, you must similarly do it right there and then and there and not some hidden away portion. That is the thought. Similarly, if you have the Data Protection Board is again a unique piece of legislation institutionally in the evolution of laws across the world, in as much as it says that Data Protection Board shall be a digital office. That means it shall not hold hearings of the kinds which we are used to. It will be, as it is described there, an online grievance redressal, online resolution mechanism. So it is just like you have today an issue with Amazon or somebody, you submit your grievance online, at a click, the person can submit their complaints to the Data Protection Board, and entire process right till disposal shall be online. So again, it's very easy for people to access this whole system and to operate. So I just gave you a few of the pointers, but the point I wanted to underscore was that a very modern law and easy to seek remedies under law has been designed, with good, strong safeguards. Much thought has gone into it. Not only are the best practices across global laws gone into it, but a lot of unique things which were not so far addressed in other laws, they've been covered here. And those protections are available equally in respect of the state as well as private parties. There is a lot of misinformation that has been put out that the state is somehow exempt. It is simply untrue. The state is also equally accountable, and through similar mechanisms and similar safeguards as apply elsewhere. So yes, the issue of trust, Basant, is squarely addressed by the law and by the rules that will be under it. Yeah, thank you.
In fact, sir, thank you for addressing the question of trust in such a simple language. As you said, it is the language which matters, the language of the consent, or be the language in which, sir, you have very eloquently explained to us the provisions of the law which safeguard privacy, which safeguard data of individual citizens, the data principles. I would quickly like to go to Dr. Goyal here. Sir, public sector is a huge participant when it comes to delivering health services. How do you see the improvements that are being already made in public sector healthcare delivery, as well as what is needed to improve service delivery through public sector?
Thank you, Basant. Yes, public sector, and I actually happen to represent the public sector here, being Director General Health Services. Public sector is indeed the backbone of healthcare services, as was witnessed during the recent pandemic of COVID. Had it not been for the public healthcare institutions, I think the story of COVID in India would have been very different. And I am glad this realization came to the public as well as to the private sector. Now, having said that, it's been said time and again that 60% to 70% coverage is provided by the private healthcare sector. That's because we are focusing primarily on secondary and tertiary healthcare. When you talk of primary healthcare, I think the entire focus shifts only to the public health sector. And so far, ABDM does not address the primary healthcare at all, which is a very important thing that needs to be done. So when you talk of integrating the public healthcare sector with the ABDM or the Ayushman Bharat initiative, the most important is a seamless integration with the hospital management information system, which needs to be universal. You can't have different hospital management information systems for different entities. Now, when I talk of public health sector as well, I divide them into two spots. One is you have INIs, you have AIIMS-like institutions. On the other hand, you have a number of other public health sectors institutions which are present in states as well as there are central institutions. There is a sea difference between the quality of healthcare provided by the two, but that quality of healthcare is not a reflection of the personnel who work there. It's the facilities that have been provided to those institutions, the amount of money that is being pumped into INIs and AIIMS, and you look at the money that is being pumped into the public healthcare institutions or the money availability to the public healthcare institutions. Factually, the students that join public healthcare institutions are the top-ranked people. Yet, we say that those institutions don't provide quality healthcare. So something wrong has to be within the system. So I think that's a very important point that I made. Then it's not just availability of the ABDM or the digital, the ABHA iCard. You have to have these public health facilities being provided digital infrastructure. Even today, these public healthcare facilities are struggling for a basic network of digital healthcare. There are not even, digital systems available as far as the networking of the institution is concerned. Same thing is about, I said about HMIS. The second thing I would like to say is about the lab information management system. You see, that also has to be universally available. Why can't we have an open system from the government that every lab in the country could adopt? Similarly, an HMIS that every institution cannot adopt, so that there is a seamless data flow into the Ayushman Bharat initiative. So I think I would stop here before.
Thank Thank you, sir. I think, sir, since you said that you are here representing the public sector, a big congratulations to you for ensuring that all of us are safe during COVID. It has to be, mentioned that 95% of COVID doses were delivered by the public sector, and that's a huge congratulations, sir, to you and to all the functionaries in the public sector, sir. And as very rightly pointed out, primary healthcare is to a large extent delivered through the public sector. Your point, sir, regarding making HMIS and LMIS an open source, freely available software available to everybody, that is noted, sir. But we are also working on encouraging the private sector to integrate and to develop different HMIS in order to ensure premium services, better user experience. But so your point is really valid. I would now like to move to Gagandeep, sir. Sir, your vast experience of implementing healthcare schemes in the state. With that, sir, I would like to ask you how the states are moving towards universal health coverage. Many of Indian states, in fact, 12 of them have already expanded Ayushman Bharat PMJ, and they are ensuring that all citizens of the state are covered under ABPMJ. And then, of course, the related point would be whether it is sustainable, how to fund it. Sir, you come from the state of Tamil Nadu. You're representing Tamil Nadu. Sir, please tell us about your experiences in that respect.
Thank you, Basant. And we need to expand the healthcare system, and I feel that it is very important that the benefits of digital mission have to be known to the people. I think the states still do not understand the importance of visibility. That if a patient is there, if the healthcare professions are registered or the healthcare facilities are registered, that the citizens can themselves access the facilities using their own computers or cell phones, etc. That benefit is not known to a large number of citizens across the states. My take is in this, that at present the digital mission is actually you have not made it mandatory. It is the states for themselves to take a call on this. My experience into the governmental system of things is I feel everybody does agree to the fact that the digital mission is actually beneficial to all the states. So slowly and gradually, Government of India can actually link the implementation of the digital system to various schemes. Maybe a slight sort of funding to the schemes, a slight nudge can be useful in bringing all states on board. So that is my most important point which I will like to give to you over here. And the second is, I second Dr. Goel stating that we do not have, the concept is there, and the concept of 14-digit ABA ID is there, a 12-digit healthcare facility ID is there, etc., or the healthcare professional ID is there, but there is no standardized system at present. For example, I'll take the case of Tamil Nadu. We have HMIS in implementation since last about 14 years. Now we have an outdated system in our opinion, and there are 12 modules. We want to make all modules into a standardized module system, including the LIMS module system. Now we find that across various states, HMIS is not standardized, including I have had interaction with the other state secretaries also. I will suggest that if, and of course at present now we are, for example, though we had an earlier system through TCS, now we are now in talks with CDAC, another PSU, for standardizing it. It's high time if we have a standardized module system that the states can further improve that, and it should be available like to the states across the board, so that we don't have to waste our time for 5-6 months for making the modules conducive to our states. We can simply pick up from you in this regard. This is my second suggestion in this regard. Third is, I also find that healthcare professionals do need a lot of training and orientation into this. like I will like to say that I have been Secretary Rural Development for a long period of time, and I have implemented MG and REGS. Actually, what I found was that the ministry, along with NIC, they actually trained a large network of people down in the field level also. And similar sort of a training system, I wish that under your leadership we can do. We want NIC to be involved in that, NIC and some other agencies to be involved in that, so that the training, one of the administrators in the districts, the director, the CMOs, the joint directors of health, the deans of medical colleges, the usefulness of all the modules of HMIS, and then of their technical personnel into the standardized format of things into the entry system, and cross-learning exercises across the states, etc. Actually, this all will actually galvanize all the states into implementing in a very short period of time. So these are all my thoughts about how the digital mission can actually take off. You have taken off in the first 2 years, a very good base has been built. Now it's the time to actually extrapolate it all over the districts, and we will like you to take up the action in this regard. You also mentioned about how the states are trying to fund the schemes. Of course, I would like to mention then there is a separate session in which we will also be speaking, but over here I would like to mention over here, under the PMJAY and of course state-funded scheme, we have married the two schemes together. What we have done is that all the government hospitals, in fact Tamil Nadu is one of the few proud states wherein under the PMJAY scheme, whatever is the expenditure, in fact, we have one of the highest expenditures being done by the public sector hospitals, our governmental hospitals. We have 50% government, 50% private. So that is the very advantageous position. And government of Tamil Nadu has actually passed a governmental order wherein a specific percentage, 27% of the income that is accruing to the government hospitals, actually we are bringing into a corpus fund, of course, and also a specific fund. We are also earmarking, allowing each hospital to earmark for its infrastructure. So I have now a system wherein the major, most important medical colleges across the state, Tamil Nadu has 36 medical colleges. Many of those medical colleges are more and more becoming self-sufficient in terms of infrastructure. The deans don't really come to me for each and everything. We have empowered the committees of deans. We don't want the governments to take the decision. We have put the system, the committee of the deans and the professors and a few important people in the hospitals. They are the decision makers in terms of the income accrued to the hospital, how to improve. They actually go for new machinery. In fact, there are many hospitals in Tamil Nadu which have started their the comprehensive healthcare system, buying the machines from the funds which they have accrued out of the income over here. And those healthcare systems, they also charge, which is further generating income for them with which they are expending. So I'll explain about this in the next session, but these are my few thoughts about in this regard. Thank you.
I think Sir has very rightly told us that NHA to lead, though NHA also believes we are looking at leadership from the states. We are recognizing all the best practices of the states, and Tamil Nadu has really done well in this regard in PMJ. And sir, your point regarding understanding that even the healthcare professionals need more exposure, more learning, more training for how to move to the digital way of health. And that's well taken, sir. No discussion on universal healthcare is complete without a discussion about the missing middle. Missing middle is, all of us have a vision of a different way of looking at missing middle. It is the people, the government takes care of the poorer ones, the richer ones take care of themselves. It is the middle which everybody forgets about. And I would like to take this question forward to Dr. Indu Bhushan, sir. Sir, please do shed some light, because we are every day talking about it. We at a policy level, all of us are thinking about it. Sir, please tell us how to achieve, how to cover, ensure that missing middle is covered.
Thank you again, Vasant, but before I come to missing middle, let me just pick up on where I left, and also Dr. Atul mentioned. So if I gave the impression that public sector is not important, I think that was incorrect, because public sector, of course, plays a hugely important role in universal health coverage. I had gone to Tamil Nadu once and gone to a hospital, and it's a public hospital, and so one of the patient I saw from Ayushman Bharat, and I asked him, why did you come here? Because the outside there's a private hospital. You could have gone there also, because I had gone there. He said the quality is better here. So I came here because of the quality. And there is a research to show that in all those states where public sector is good, the quality of private sector is also good. And where public sector is not good, private sector is also not good. And so public sector sends that benchmark and watermark that private sector has to follow. So I think public sector has to play a strong role in assuring good quality, and good quality to large number of people, and for universal health coverage. Now coming to missing middle, of course there are large number of people who are not rich enough to buy their own health insurance, and not poor enough to be qualifying for any government schemes. So we have to take care of them, but there are some problems in covering those. One is how to cover all of them without what we call in our parlance adverse selection, that once we open it for all of them, only those people will come for, say, voluntary health insurance, even if subsidized, who are likely to use services. So we have to have schemes where all of them are covered together as a group, so that there is a risk pooling. It's not just only high-risk people who come and join this service or this scheme, but everyone with low risk and high risk, rich and old, rich and poor, but also young and elderly, all of them are part of it. And therefore, the scheme has to be universal, and their government can provide a certain kind of a subsidy, and we can encourage a large number of people to enroll if they have to pay. So, but this is a complex scheme where probably Dr. Paul has been working on it for a long time, and we've had a series of discussions on how to include missing middle. But ultimately, the entire country will have to be covered, because unless everyone is covered through some mechanism for catastrophic illnesses, I think our goal of achieving universal health coverage will not be achieved. And other option is to cover everyone in the country for certain kind of health conditions. For example, for trauma, if a person comes to a hospital, we should not be asking whether they are covered under some health insurance, are they covered under Ayushman Bharat. They should be provided services irrespective of that status. Similarly, for certain kind of very serious health illnesses which are catastrophic for even rich people, I think that should be covered entirely. And so that kind of some scheme where certain kind of disease is covered for everyone, and for others probably there can be some voluntary health insurance, keeping in view that we can also address the issue of adverse selection. That will be the way to go.
Thank you, sir. And you know, when we talk about the digital mission, we talk about unique identities. We talk about ABHA, the Ayushman Bharat Health Account. We at NHA pride ourselves with you know, the capacity, the power which ABHA brings to implementation of the digital mission. And I very briefly you know, interacted with Amit Agarwal sir, and I asked him how ABHA you know, is built upon, which is built upon Aadhaar. Is it Aadhaar of healthcare you know, sector? And he was very quick to say that, you know, Aadhaar is the main Aadhaar. So I will rephrase my question, sir. all the registries of Ayushman Bharat Digital Mission, not only ABHA, but also the HPR and HFR, they do utilize Aadhaar for establishing the unique identity of any player. And just like e-sign, eKYC, all financial transactions, they are built with the underlying Aadhaar on it. So, but we do feel that since there are restrictions on storing Aadhaar, Aadhaar data, Aadhaar information, ABHA does, sidestep those issues, and it does help us to store and link health records to unique ID of the patient. In this regard, sir, I would like to ask you to tell us about whether we are going the right way by developing a whole infrastructure around ABHA. How does ABHA facilitate what Aadhaar cannot? So I'm just trying to rephrase my question, sir.
Lest you infer that I was being proprietorial about Aadhaar. No, let me clarify. That was not the idea at all. Aadhaar was the foundational ID. Since it is the unique digital ID of a person, it has to be safeguarded. And that is why it was without intelligence, because as I said, the act makes the authority purpose blind. I cannot know the purpose for which Aadhaar is used. And it is not for any sector. It is just simply an ID with just the biometrics of the person, the name, the gender, the date of birth, and the address. And optionally, if you want, we can have your mobile and email ID, nothing else. So it is just pure digital identity. Now, when you apply it in a context, you may want more purposes, you may want to exchange. In order to preserve the privacy of Aadhaar, we require that even if you are using Aadhaar for authentication, even in that secure Aadhaar vault, which is maintained by any Aadhaar using agency or KYC, eKYC using agency, AUA or KUA or requesting entity as we call it, it should be stored in a masked manner. It should be used in the form of a token, and the full number, etc. should not be used. The whole idea is your Aadhaar should remain very secure and should be used in a very limited, trusted fashion. However, if people are going to communicate between various health service providers and health seekers, or for that matter, like you are seeing in the financial sector, financial service seekers and providers, then you need a means to communicate information. You need some index, you need some identity which you can store and so on, without exposing Aadhaar unnecessarily. So, like I said, Aadhaar is a digital identity, and there is always room for anybody to create for their own purposes various IDs. The largest use case we see of this is now emerging in the financial sector, which is the account aggregator framework. And that's basically a consent management framework. The account aggregator has no visibility, is data blind. And here they just enable seekers and providers of information to exchange information with the help of an interoperable platform. And NHA is already providing consent management services. The Digital Data Protection Act also provides and envisages a consent manager, which would be similar services. A consent manager would be accountable to the person, to the data principal, which is the person to whom the data relates. He is not accountable and may not to the data fiduciary. And he is supposed to operate through an interoperable platform in a similar manner. So, except that it is not the data fiduciary, so the consent manager must be distinct from the data fiduciary, which is the person who makes use of the data. So, under the law, therefore, whatever consent management structure is there should be distinct from the person who's doing the processing of the data, cannot be the same person. That is what the data protection law means. So once you create an ABHA kind of an identity and sufficient, and similarly you have that 12-digit identity for health service providers, it becomes very easy to exchange information, to pool information, to get data aggregation benefits, service aggregation benefits, and all the other things which Basant presented at the outset. So that is what it enables, and therefore that's a very powerful thought and with immense opportunity for the sector.
Thank you, sir. Your words mean a lot for us. And your vote of confidence in ABHA is really appreciated, sir. Thank you for that, sir. I would, one last question I would like to ask Dr. Goyal here, sir. Sir, one aspect of universal health coverage is also ensuring that there are adequate number of healthcare professionals, not only doctors, but also nurses, all other allied healthcare, paramedics, all kind of professionals who are involved in healthcare. Sir, we would like to know from you what steps have been taken during the last few years in order to ensure that there are larger numbers of those health professionals available. Let me also tell you, when I did my MBBS, that the number of students appearing for each MBBS seat would be like, one seat would, 10,000 people would be contesting for that one seat. I hope that number has improved now, sir.
Tricky question, I'll try to answer it. I think we have seen the number of MBBS seats as well as the post-graduation seats go up a huge amount. We have over 1 lakh MBBS seats. We have close to 70,000 postgraduate seats. Simply increasing the number of seats is not going to ensure universal health care unless we start looking at, one, the quality, and we also assure that these people are at the right places. And you see, our stress is only on secondary and tertiary healthcare. In primary healthcare, we still do not have medical professionals at place. In the so-called health and wellness centers in the rural areas, we are still manning it by trained paramedical personnel. And for that, there has to be a sea change in the thinking of the people who run the health services. A trained professional, a well-trained professional at the primary healthcare sector gets peanuts when compared to the people who get the salaries that are given to tertiary healthcare people in cities. So unless that thinking changes, you want a doctor to go and serve in the rural areas in the primary healthcare center for 30,000, 40,000, which is not going to be the case, 50,000 at most. So that thinking has to change. And let me tell you one more thing. You will never be able to even take care of the missing middle unless the cost of healthcare is brought down. If the cost of healthcare goes down at the rate it is, keeps on going up at the rate it is, well, you will never be able to ensure universal health coverage. And for that matter, since you restrict packages for Ayushman Bharat scheme, why can't the same packages be available to that missing middle when they go to the private sector? Why the private sector is allowed to run amok for the charges they place? You see, an X-ray chest at a place like, I won't name the private sectors, but it costs 800 rupees for an X-ray chest. It makes no sense. It makes no sense. So the same, the payment that is made under the Ayushman Bharat, why can't that payment be restricted to all other people who are approaching that private hospital?
That's a good suggestion, sir. But we need to remember that we are all living in a society, a country where private enterprise is admired, sir, and different type of clientele, they are looking for different kind of services. But yes, it doesn't take away from the fact that the same services at same prices can be offered to missing middle. Of course, that can always happen, and maybe that should be the case going forward, sir. So cost of healthcare is indeed a major barrier to expanding to universal health coverage. With this, I would also like to invite maybe a few of the people who have been listening to us for so long and so patiently. I would like to invite, maybe with a raise of hands. Yes. So we do have few. We have the mic. Can we have the mic here? Yeah. So we request the audience also maybe to go ahead and ask a few questions. We have time for maybe 4 or 5. So, and I'll request the speakers to keep it brief. I will request the person who's asking the question to maybe introduce briefly and then ask the question.
I am myself Dr. G.K. Pal, the Executive Director of AIIMS Patna. My question is to Sri Amit ji. Sir, actually at AIIMS Patna, what the problem I am facing, even about 10% of the population, they don't have even Aadhaar card. And many do not know actually about the awareness that was being discussed here. Even they do not know actually that there is such schemes are available. I do not know actually how to address those people actually. And the number two, sir, question I have, that when they come for this Aadhaar registration, often we face actually the HMIS fail actually. I mean the hospital management system, where now we have to, it takes little longer time also for registration. I do not know if from the National Health Authority kind of system can be provided where you can have better easy registration, and because often the connectivity actually fails. Even that, especially in the morning time, until the practical things, we have a robust system by the CDAC, but in spite of that also, when there is so much of load actually, the registration actually fails. Whether a system can be generated, maybe a developed kind of machine can be provided, where with low connectivity, and the registration can be done, or the hassle-free registration can be done.
Sir, please be seated. I would request the audience to keep the questions short. Sir, please reply.
On the first question, so Bihar is not among the states which has a low Aadhaar penetration rate, barring the hill states and the northeastern states. Today, Aadhaar penetration is close to saturation in almost all states, including Bihar. So I'm a bit surprised when you say that you're coming across 10% of the patients not having Aadhaar. I'll have to... Not linked with mobile. Yeah, that is an issue. It is not linked with mobile, but increasingly what's happening is, you see, if you look at the evolution of Aadhaar, what has really happened was, the first use case of Aadhaar was DBT. So government departments went around trying to seed the Aadhaar number on a self-declared basis, people's Aadhaar cards, etc., and to seed the database. And that payment simply happens directly through the Aadhaar payments bridge. So a batch file of the payment goes on the PFMS platform from the beneficiary database with the destination bank, and at the bank end, using the NPCI mapper on the Aadhaar payments bridge, it is credited, the relevant account is found, because the beneficiary has feeded the Aadhaar database and the bank has also seeded. At both ends it is seeded. So it goes to the bank and bank is able to look at the DBT account and credit it. So there is no authentication involved, there is no mobile number needed here. So those kinds of use cases still remain. That is where we started the journey. Now increasingly what is happening is departments are, and that kind of use of Aadhaar took care of the problem of double entitlement. I mean, India was notorious that you could have multiple ration cards and pilferages in that system, and that is what was the case. And those things have progressively been addressed. Now from that we are moving to a universe, we are looking for either frequent validation of identity. So for example, the life certificate, Jeevan Praman, or now in PM Kisan also we are revalidating identity, so that it shouldn't happen that you just establish your identity once and money keeps on flowing to a person even beyond death or whatever. Or if lifting of rations also, not just that you get a ration card after authentication, but at the picking of the rations also at the fair price shop, you are being checked again. So and increasingly people are using to access all kinds of service in a very easy, powerful manner, financial services, every kind of services. So people are getting used to the idea of mobile OTP, and now with this January, face OTP, which is very simple. So you can do your Jeevan Praman now in a faceless fashion. Just blink your eyes in front of, download the app, blink your eyes in front of your app, and your Jeevan Praman is done. Life certificate is done. That kind of a thing is happening. So as this happens, this will very quickly drive up the mobile seeding. Agreed, today there is a good number of people who have not seeded their mobile, but as they find the ease and convenience of it, everybody would want to seed their mobile, because the other way of doing things is simply doesn't make sense any longer for anybody, for the user themselves. So yes, this gap is there, because again we started from a place where people thought that there are a lot of concerns, so we did not insist on anything. And back when, if you recall, 2010 Aadhaar started, many people in this country did not have mobile phones. Today the country is at saturation point. Everybody does have a mobile phone, everybody does know how to use it, everybody is used to an OTP and wants to use it. So this should change pretty quickly.
Can I take a question, please?
Yeah, well, raise hand at the back. If you can maybe say after this person, please.
Yeah. Hi, sir. From a private health insurance perspective, Sachin Agarwal here. we read in Tamil Nadu there's this partnership with, I think, Google Health around also digitizing some of the public health records in hospitals, and then the same data available in a public health record could at a certain scale. So who is
the question addressed to?
Mr. Bedi, sir. Right. So there is that a project which is ongoing, and then because data at that scale from a consumer PHR could be used to build products and then underwrite those products at a certain scale and bring down the cost of health insurance for missing middle.
I would like you to just kindly repeat that Google Health. What did you mention about Google Health is doing this thing? That's what you are asking me?
Yeah, there was some article around Google Health and Tamil Nadu government collaborating on digitizing health records in public hospitals. I'm not...
Okay, actually Tamil Nadu government along with the World Bank, we are actually creating a public health registry. Actually it's sort of a sister scheme of what ABDIM is there, and we had started it from 2021 onwards, which we are piloting in one district, in which besides taking the ABHA ID for each family, actually we are also sending our nursing paramedical staff and collecting the basic health parameters of each and every family the citizens, and that we are also digitizing. We have completed for one district. We plan to expand to the other districts also. So that's why we are actually interested that it will be sort of an expansion of what the ABHA ID is concerned, but it will also have the records, will also have the basic health details of each and every person, which would have been collected at his house, his height, weight, BP, etc., NCDs, etc. So that we are collecting. So we will be, if you are interested, we can actually share this data with you on a personal basis.
Sir. Thank you, sir. Maybe, yes, please go ahead.
Good evening. I'm Dr. Shogat Rai, and I'm from the Indian Navy. My question is firstly general. Thanks for the very excellent discourse on ABDM and PMJ. One very important part is I think there are a lot of challenges which came out. I think more challenges than maybe what has been implemented, and one I think I just add to it is that health is a state subject, and that's one major problem. My main question to NHA actually is that if we are talking about ABDM and Ayushman and sustainable, I mean we are talking about this universal health coverage and ABDM. Now, universal health coverage is measured by I think two methods. I mean that is, one is what is the essential service that has been provided, that is I think SDG something 3.8 or something, and the other one is the catastrophic spending which has been carried out by the people, so that is 3.8 SDG. So have you done in the last 2 years from the time ABDM has been initiated in the country, any such measurement has been done? See, I mean showing how many people have been have got an ABHA card might not actually come, you might not get a measurement of the impact of ABDM in the universal healthcare.
Okay. So, number one, it is not nice to ask the moderator these questions, but I'll certainly, try to answer on behalf of NHA. You're right to an extent that ABDM does not capture this aspect, but I think PMJ, the Ayushman Bharat PMJ scheme, the way it has impacted lives and it has delivered services to the needy, and it has prevented a lot of out-of-pocket expenditure from, otherwise these people who have been treated under the scheme would have to pay for these services, and this would have led to catastrophic expenditure, pushing people into poverty. And please do remember, the clientele that PMJ serves is the bottom 40%, people who can hardly make their ends meet, for whom maybe food is a more prime concern and health is still a later need. And those are the people who are covered under the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And quickly, we are also conducting studies to establish what percentage of people who were treated would have actually gone into poverty had they not been provided this support. And also we are in the process of studying how it has impacted the lives of people in fields other than health. The money that has been saved for the clientele, for the people, for the poor people, how that money has helped improve, helped achieve other aspects of life. Maybe a kid would have been thrown out of school because of catastrophic health expenditure. Maybe a young girl, an adolescent girl, would have stopped attending her school. She would have dropped out. So we are also trying to assess how protection in health affects other spheres of life. We are also trying to assess how a lady who's suffering would be left by her husband's family, left at her parents' house, and once she gets the treatment, how she is taken back into her husband's family. So these are the impacts which we are trying to study and we are trying to establish. You're absolutely right. Catastrophic health expenditure, even for people who are guaranteed so much by the government, who are having so many facilities, in the face of a big disease or a big expenditure, all of us do also fear. But imagine the state of a person who's living right on the edge, who has to borrow for his care. So I think, thank you for bringing that up, but we will come out with the right kind of data and the studies to establish how effective PMJ has been in preventing people being pushed back into poverty. Maybe we can have one more question. Yeah. Oh, you already have the mic, please.
Yeah. Okay. No, thank you so much. I'm Sanjay Pandey from Global Health Advocacy Incubator. And it was really very nice Vichar Manthan which was going on, which has stimulated few thoughts on that. So just two questions. Number one, you talked about poor people, they don't have to pay, no pay. The rich people, they have full payment. So there is a middle one, which are missing number, which they have to do the co-pay. So can't you think of some mechanism, some modalities to really have those co-pay to include this? That's one thing. And second question is about what about the ethics? Because you must be facing challenges from the demand side moral hazard issue and from the supply side moral hazard issue. So in the entire these things, the big challenge is the moral hazard issue itself. So how the ethics is really running this equity? So that's two questions on that. Right. Thank you so much.
So though I think you addressed these questions to me, but I would like to deflect them to Dr. Paul, and quickly I would request the chair to intervene.
Sure, sir.
We are joined here by one of the visionaries and one of the biggest champions of health here. I would like to bring Sir here he's been quietly listening to all of us. He is listening even to the audience questions. Sir, this question is for you, and you have to guide us all. I would also request you, sir, to maybe bring out the efforts which the government has already made in this regard. Sir, we are looking forward to your words of wisdom. I apologize to all the people who were waiting to ask questions.
Sir, can I, because my question is also to Dr. Paul, and I think that a woman should be given a chance in this.
Please. My heartfelt apologies to you, ma'am. Please do come, and I do believe that, and thank you for asking the question to Dr. Paul, because that helps me. Thank you.
Thank you very much, sir. So I think that in this August gathering, it should be a point that in case only male people are answering, please find out that maybe a woman has something to say. I am Dr. Manorama Bakshi, sir, and I have been in public health domain working for last 25 years. And my question is to all of you, sir, actually, and particularly to Dr. Sir, Basant sir, you said in the beginning that there has been surplus, and I should salute Ayushman Bharat for the social good it has done. But along with this, sir, what you spoke about surplus, that surplus is there because investment have been for the lowest set or maybe 40% in those small diseases like maybe diarrhea, maybe cleft lip, maybe something of the, but in Ayushman Bharat Health Benefit Package, wherein we have the ischemic stroke, how many ischemic stroke people have come and done those ischemic stroke cases? How many people have been doing for the dialysis, sir? Because dialysis every year almost 2 crore people are happening. I do agree that we need to have a lot of prevention measures in place. I do agree that When it comes to the preventive medicine and preventive advocacy, that should be the number one. But what about those who are already there? So my request to you is, one is about, we are talking about Make in India also. I have a couple of questions, sir. But when people come with Make in India kind of things, especially in the dialysis unit, when we have the startups who want to reach out and do the dialysis services, because every year 2 crore people are adding to this cohort. But then, unfortunately, we are not having the kind of engagements they should have with different DGHS, CGHS, or those kind of things. So these are a couple of questions, sir. I have been raising it again at various platforms, and I would like you to address. Definitely we are doing a lot good, but maybe if we can look into these kind of things also. Thank you so much.
Sir, before you answer, thank you, ma'am, for the question, and thank you for reminding us. I think, sir, these packages for regarding, you know, the more complex procedures, tertiary procedures, especially ischemic strokes, these packages are now being included in PMJ, sir, and especially dialysis packages. A lot of volume of PMJ is with dialysis, but we really want to move beyond it. Our health benefit package today is 1949 packages. We are always evolving. We'll be very soon, I don't want to make any announcement, but very soon we'll be coming out with our newer version of health benefit packages. Ma'am, I would like to invite you, and in fact invite all the you know, people present here. Please do come together with us in developing these packages. All inputs are really welcome. Sir, over to you, sir. Quickly, sir.
Thank you very much. It has been a fascinating panel, incisive questions and wonderful answers, and also wonderful questions from the audience. Let me give my reflections in 4 major points. Firstly, let us also be reminded this evening once again that healthcare has impoverishing effects. Going by the NSSO 71st rounds, 75% population plunges into poverty. These are reminders in this, because we're going to have a lot of discussions today and tomorrow. And it's estimated at 3.4 crore people. That translates into 3.4 crore people getting into poverty each year, even now. So we have to address this issue in under the overarching paradigm of universal health coverage. It's just essentially a reminder. First and foremost, the point was made with regard to enhancing the coverage of health insurance packages. That's the first point that we heard from Basant. How do we go about doing it? Convergence versus and plus minus expansion. Now, convergence is essentially for bringing disparate schemes, often small, often fragmented, into one umbrella so that you can deliver it efficiently, and you deliver without double dipping. You deliver it in such a manner that there are maximum benefits. One such benefit, of course, is that it stems from digital pathways, but also through strategic purchase across the packages. So convergence is a great goal. One by one, we should, have people agreeing to converge into the larger scheme, and this is the way forward. Many nations have taken a journey from a fragmented system toward an integrated system, and this must continue. Already several of the smaller programs in one way or the other are converging into the Ganga of Ayushman Bharat. But the critical part is expanding coverage. And we need to think about how to go about doing it. We heard that 40% individuals are being covered essentially, in principle. 40% people are targeted under Ayushman Bharat. State governments have used their own tools to go to higher ranges in respective states with respective populations. But there is a huge work that needs to be done in this regard, and we would welcome your suggestions today and tomorrow how to go forward in doing so. I did an estimate with my team in NITI, and we discovered that the current 40% household expenditure per month corresponds to about 12,000 rupees. If you go by 2 more quintiles, at that point the household expenditure is about 17,000 rupees. So 12 and 17, not exciting. Not exciting in the sense that this quintile also needs coverage. There is a huge unmet need. 12, what is household expenditure of about 17,000? A very, very modest family. 5 people, 4 people, and so on. So clearly, Basant, the thrust of our effort should be to expand. Now, how do we expand? We heard a suggestion that pick up on some areas, some treatment and some conditions, go universal through public money, go universal through also insurance mechanism. We look forward to getting ideas on this, because at 5 years of Ayushman Bharat today, we would look upon ways and means of taking a plunge into a more expanded version. And I leave it there. Clearly, a part of this has to be an affordable product, which this kind of a group, people with 17,000 income, expenditure, 15,000 expenditure, can make use of. And that's a challenge. I want to express my, like I would say, sorrow and sadness that in spite of trying very hard with the insurance systems, including the insurance regulator, we still have not found an exciting insurance product which gives 5 lakh coverage for the family, and it is within the range of the people whose expenditure level I am talking about. The typical acceptable insurance that seems to be making sense is about 24,000 per annum, 28,000, 57,000. If you add an elderly, 43,000. My team did those analyses. This is not going to work. We need to find the choice of going in for an insurance coverage which is affordable to this middle belly to which the reference was made. And that's where the possibility of co-payment and other aspects can be. Sure, we should look at those models, because PMJ is a vanilla product. It covers in a certain way. There are higher dimension and expectation than if you come in either by insurance or through other mechanism. It's open, but we don't want to take that plunge till we know that the co-payment mechanism, for example, will not be misused by the private sector for underhand deals and distorting the entire trust that we are trying to build with people. So that's my first input, that indeed we need to go in the direction of expansion. We need to see how citizens can contribute toward meeting the expenditure so that the whole mission, the scheme remains viable, remains sustainable, and it moves from small packages to mid-sized packages and to larger packages, but does not compromise on the quality and does not go unmanageable going into future. My second point is, again, a bit of a disappointment. We would have expected that the private sector, large chains in particular, should have lapped up the PMJ as a panel hospital. You tried, sir. We all tried. We made a significant headway. We had 12,000 plus private hospitals. We are very proud. We are very thankful. We are serving the nation, because ultimately after PMJ there is only one system. It's not private or public. It's one system, India healthcare system. We are connected. I urge that the private sector hospitals, small, medium, or large, as per the empanelment requirement, may please join this, because this is the scheme that's going to stay. All the other small rivulets are going to join this Ganga. So I request once again, and if there are issues about the package rates, package issues, please come forward. We have improved our efficiency of payments. Everybody tells that payment systems are much better than X, Y, and Z. So not having, all the private sector lapping up on, especially the ones who are larger chains, is rather stressful, and we would urge that we move in that direction. And one aspect of that is to increase the private sector infrastructure in a big way. Again, the progress in that regard is less. UHC cannot happen unless there are services and infrastructure available. At NITI, we are trying to rework on our PPP initiatives. We have had a VGF scheme. We have had also from the RBI, priority lending systems are available, but not making headway. The Honorable Minister of Uttarakhand was whispering into my ears and saying, look, we want more private sector to come into Uttarakhand. What is it that we can do? Electricity, land. So please, let's have a dialogue on how to enhance going forward in next 20 years. but more importantly, giving a big ignition to increase in the private sector infrastructure, the government infrastructure with 150 new medical colleges, district hospital, critical care unit, mother and child block has been making steady progress, and more of it will come. But we need private sector hospitals for a scheme like this to be helpful and making a big push for the USC. My third point, and now I'm going to be brief, is very wonderful words spoken by Dr. Bedi. The money that comes through the scheme to the public sector, medical college or a hospital is there to stay. I urge the state governments to really put that to a good and efficient use and use it as a tool for the public sector teams to be energized and public sector hospitals, medical colleges, other hospitals to really improve their services and be more motivated. In the original notes, we had written that part of this money can go to the healthcare teams themselves. Please do so. For setting up little infrastructure, repairs, maintenance, please do so. And think about the beauty of the scheme. The money, public money, goes to the private, but whatever comes to the public goes back into the public sector. It comes back from the government for the service of people to the public sector, and that's roughly 40% of the money we guessed. My last point is with regard to ABHA, ABDM. Only one comment I like to make. I think a big push for ABHA is great. One important, it is a must. That's the only way forward. But loading it with ECR is an important necessity. The question that I asked is, what is there in it for me as a citizen? This is what we would like to crack this year, and we look forward to your suggestions, how the ABHA can become something that the citizen owns and is proud of and uses it at opportunities that are not too far in between for whatever reason. Its usage at the site of care, its usage in the OPD setting, in the district hospital setting, or other ways. Because unless that happens, ABHA will not be respected by the citizen. And ABHA needs to, is needed going, as we move into future for more than one reason. But then for this to be attractive, let's address what it can do for the citizen more often than an occasional episode that might excite him or her. That will be my request, but we're very proud that the 5 years of journey of Ayushman Bharat PMJ and 2 years journey of Ayushman Bharat Digital Mission is exciting. It has been noticed by the world. It has benefited people at large. It has wiped many tears from the eyes of our brethren and sisters, women and children. And we need all of you to please help the team here, all of us on the dais, let's say, to please craft the additional elements that you are discussing in terms of a wider reach, higher quality, attraction by the public and the private sector to make it even a greater success as we move on the path of Amrit Kaal. Thank you very much.
Thank you, sir. I think those were wonderful words and wonderful message for all of us. I think one underlying message has been more. Ye dil mange more. It's something of that sort. Sir, we want more from NHA, we want more from PMJ, and more from ABDM. We want more from the public sector. We want more quality, more empathy from the private sector. We want more trust from the government. And we want more action from our insurance companies. Much more action from the state government. And the audience wanted to ask many more questions. So I think the one underlying theme of this session has been more. And we are all looking forward to doing more in health. One thing which I think is very encouraging and which will probably help my team during the conduct of the whole of the Arogya Manthan is the unfulfilled, satiation of the questions of the people here, of the audience. So I think that we'll try to address. I think many ideas which our speakers have left us with, those ideas we'd like to develop here. And as Dr. Paul here, sir, has said, please do help us build, help us take this journey forward into the coming year. I think that is another aspect which we need to build upon. So for me, it's always more. Thank you. Thank you.
Thank you so much. As we conclude, we'd like to present mementos to our esteemed panel. First, if I can request Dr. Garg to present the memento to the chairperson, Dr. V.K. Paul. Now may I request the chairperson to please present the mementos to the panelists, starting with Dr. Indu Bhushan. Dr. Atul Goyal. Shri Amit Agarwal. And Shri Gagandeep Bedi.
Thank you, sir.
Thank you so much. Just a reminder, there is a, behind the placard, there will be the ID card, there will be a QR code. You can scan that to share any feedback with us. Thank you so much. Please, you can proceed for tea outside again.